Welcome back to another deep dive. Today we're zooming out to appreciate the sheer overwhelming scale of the phylum Arthropoda, and then we are going to zoom right back in microscopically to see exactly how they try to kill us.
And overwhelming is really the only word that fits here. It is honestly staggering when you actually look at the numbers.
Yeah, I read this statistic in the source material, Murray chapter 77, and I literally had to put the book down and just stare at the wall for a second. Arthropods make up approximately 70 to 85% of all known animal species.
It really puts our own existence into perspective, doesn't it? Like if you were to round up every single animal on Earth, every bird, every fish, mammal, reptile, 7 to 8 out of every 10 of them would be an arthropod.
So ecologically speaking, it's their planet. We're just leasing space.
Pretty much.
But for us, for humans, and specifically for you listening, if you are in the medical community, they aren't just neighbors or, biological curiosities. They are direct threats.
Yeah.
And that is what we are unpacking today. We're tackling Murray's Medical Microbiology, Chapter 77, with some really great reinforcements from Joette's Chapter 46. We're basically calling this deep dive Arthropods, the vectors and the vicious.
I really like that title. It captures the duality of the problem perfectly.
Because as I was reading this, it seemed like there are two main distinct ways these creatures mess with us. There's the direct assault, the bites, the stings, the burrowing right into your skin. That's the vicious part.
Right.
And then there's the delivery truck model, where they are just the vehicle for something much smaller and much deadlier. That's the vector part.
And that is the core mental model for this entire subject that you really need to hold on to. You have the direct aggressors, where the arthropod itself is the pathogen or the direct cause of injury. Think venom, infestation, or actual tissue destruction.
And then the vectors.
Exactly, the vectors, where the arthropod is essentially just a flying or crawling syringe transmitting viruses, bacteria, or parasites. And frankly, if you look at history, the vectors are the ones that actually changed the course of human civilization.
And the battlefield for all of this, the skin.
The skin interface, yes. This is the conceptual anchor I want you to visualize as we go through this. The skin is the physical boundary between the human host and the outside environment. Arthropods represent the breach of that boundary.
They break the wall.
They do. Whether it is mechanical injury from pincers, toxin injection from a stinger, or pathogen transmission from saliva, it almost always starts right there at the skin interface.
So our mission today is to completely dismantle Chapter 77. We're going to march through the taxonomy from the many-legged crawlers to the 8-legged terrors, and finally the 6-legged flying vectors. And for the students listening to this right now, we're going to flag the high-yield exam differentiators all along the way.
We will focus heavily on building those mental models so you can immediately tell your necrotic bites from your neurotoxic bites and actually understand why a tick bite can paralyze you without a single bacterium ever entering your body.
Let's get into the roadmap. We're starting with the somewhat overlooked ones, the Myriapoda and Crustacea. Then we move to the stuff nightmares made of, the Chelicerata, which is your spiders, scorpions, and ticks.
The heavy hitters.
Yeah, and we finish with the Hexapoda, the insects.
The Hexapoda section is going to be incredibly dense because that's where the big 3 vectors live. But we'll get there. We'll pace it out.
Okay, let's unpack the Myriapoda first. This brings us to centipedes and millipedes. Now, I have to admit, I always get these mixed up visually. They both just look like alien trains to me. Which one is the actual threat?
This is a very classic exam distinction and honestly a good practical tip if you are out doing gardening. You need to look at the legs and the overall body shape. Centipedes are the ones you need to actively worry about.
Okay, what do they look like?
They are generally flattened, elongated, and if you look closely at the segments, they have exactly 1 pair of legs per segment.
1 pair per segment, flattened. Got it.
Millipedes, on the other hand, are generally completely harmless to humans. They are more cylindrical, sort of like a tube, and they have 2 pairs of legs per body segment.
So twice as many legs.
Right. And behaviorally, they are detritivores. They eat rotting leaves and plant matter. They aren't predators. They aren't looking for a fight with you.
So if it's got 2 pairs of legs per segment and looks like a tube, just let it be. But if it's 1 pair and flat, take a step back.
Generally, yes. The reason centipedes are medically significant is right there in the anatomical diagrams in Murray. The very first body segment has these modified legs called maxillipeds.
Poison claws. I saw that in the text. That is a seriously metal name for a body part.
It is entirely appropriate, though. These aren't just chewing mandibles. They are literally hollow fangs connected to venom glands. They use them to capture and paralyze prey, but in humans, they can produce a very, very painful bite.
But Murray mentions that for the most part, these bites are harmless, right? I mean, it hurts a lot, but you are going to die from a garden centipede.
Context is key here. If you are in your basement in Ohio and get nipped by a common house centipede, it's going to sting like a bad bee sting, swell up a bit, and go away. However, global biodiversity is a factor you have to consider. There is a specific species mentioned in the text, Scolopendra gigantea.
The giant one.
Yes, found in Central and South America and the Galapagos. These things can grow up to a foot long.
A foot long?
Yes, and they actively hunt bats. They hang from cave ceilings and snatch bats out of the air.
That is horrifying.
So if one of those bites a human, it's a totally different story. You are looking at intense, severe pain, fever, chills, and in rare cases, especially with small children, it can actually be lethal. But for the vast majority of cases you'll see clinically, and certainly for most exam questions, the treatment is purely local.
And the treatment mentioned in the book was surprisingly low-tech. It felt more like advice from a grandmother rather than a modern medical textbook.
Epsom salts.
Right. I really haven't heard Epsom salts mentioned as a primary medical treatment in a while.
Or sodium bicarbonate compresses. The goal here is just soothing the local inflammation and perhaps using the osmotic pressure to dry out some of the surface toxins. So for the listener, if you see a question stem describing a patient who is moving trash or lifting rotting logs in a damp area, gets a really painful bite, and the treatment involves Epsom salts, you need to think centipede.
And look for the phrase poison claws.
Precisely. It's a keyword association game. Poison claws plus damp environment plus local pain equals centipede.
Okay, let's move from the damp earth to the water, the crustacea. Now, when I think crustaceans, I think of a nice lobster dinner. I don't think of a medical emergency.
And that is exactly how they get you. This is the Trojan horse concept. Unlike the centipede that attacks you directly with venom, crustaceans are dangerous because of what they contain inside them. They are intermediate hosts.
So we are literally eating the danger.
We are. The crustacean is essentially just the bus that the parasite takes to get inside your body. Let's start with the microscopic ones. The copepods, which are often called water fleas. You're looking at genera like Cyclops and Diaptomus.
These are the ones you can't really even see, right? You're just out drinking unfiltered water.
Exactly. You are on a hiking trip, you drink directly from a stream, and you ingested the copepod without knowing it. The copepod itself is digested. It dies in your stomach acid fairly quickly, but it releases the larvae of some very nasty helminths that were hitching a ride inside it.
Murray and Jaywitz linked these to a couple of specific parasites. The big one that really stood out to me was the guinea worm.
Dracunculus medinensis. This is a fascinating and kind of triumphant story of global public health. So the copepod carries the larvae. You drink the contaminated water. The larvae penetrate your gut wall, mate inside your body, and then the male dies while the female migrates through your subcutaneous tissue all the way down to your lower leg.
And this isn't a quick process at all.
No, it takes about a year for her to make that journey. Then, a painful blister forms on the foot or the ankle, and it burns intensely. So what does the human host naturally want to do to relieve a burning blister on their foot?
Put their foot in a cool stream or a bucket of water.
Exactly. And the moment that blister touches the cool water, it bursts open. And the female worm releases millions of new larvae back into the water supply, where they are immediately eaten by copepods, completely restarting the life cycle.
It's just diabolical.
Yeah.
The worm literally manipulates human behavior to ensure its own reproduction.
It really is. And getting the worm out of the host is an absolute nightmare. There's no quick surgical fix. You have to wind the live worm out slowly on a small stick, just a few centimeters a day over several weeks.
Because if you pull too hard.
If you pull too hard and break it, the worm retracts deep into the tissue, dies, and causes a massive, severe septic and inflammatory reaction. You lose the leg.
I remember reading about the Carter Center's work on this exact issue.
Yes. Former President Jimmy Carter led the global charge on this for decades. And the amazing thing is, the solution wasn't some fancy, expensive pharmaceutical drug. It was just a pipe filter.
Just a physical barrier.
A simple mesh cloth worn around the neck to filter the drinking water and catch the copepods. Because if you don't eat the copepod, you don't get the worm. We have almost completely eradicated this horrible disease from the planet just by teaching people to filter their water.
That is incredible. A super low-tech solution for a highly complex biological problem. What about the other copepod passenger mentioned in the text?
Diphilobothrium litum, which is the fish tapeworm. Here the food chain is a bit longer. The copepod eats the larva. A minnow eats the copepod, a big predatory fish eats the minnow, and then a human eats the undercooked big fish.
So copepods are really the first domino in that chain. What about the bigger crustaceans then? The decapods, your crabs and crayfish?
This is where human culinary habits really come into play. The danger here is eating them raw or undercooked. If you do that, especially in certain regions of the world, you are at very high risk for Paragonymous westermani.
The lung fluke.
Correct. The crab is the second intermediate host in this cycle. You eat the traditional drunken crab dish or the undercooked crayfish, the larvae exist in your gut, migrate right through your diaphragm, and set up shop inside your lungs.
Which presents clinically as what?
Chronic cough, bloody sputum, chest pain. Clinically, it can look an awful lot like tuberculosis. So if you are presented with a patient with classic TB symptoms, but they have negative TB tests, and there is a dietary history of eating raw crawfish or crab, you need to think Paragonymous.
So the very simple lesson here is cook your crab
thoroughly. Boil it until it's done.
Now, there is one more group in this crustacean section that Murray includes, but the book admits that it's a bit of a taxonomic orson, the pentastamids, the tongue worms.
These are biologically very strange creatures. Visually, they look exactly like worms, but molecularly and genetically, they are actually related to crabs and other arthropods. They are highly degenerate arthropods. They typically live in the respiratory passages of reptiles and mammals.
And there is a specific syndrome associated with this called Halzun syndrome, which honestly sounds like a curse from a fantasy novel.
It's a very real and very visceral condition, mostly seen in the Middle East and parts of North Africa. It happens when people consume raw visceral organs, specifically the raw liver or the lymph nodes of sheep or goats.
Raw sheep liver.
Okay. If that animal happens to be infected, the adult pentastomes, which are physically clinging to the sheep's internal tissues, can detach in the human's mouth or throat while they are chewing or swallowing the meal.
Wait, they detach from the liver and then immediately reattach to the human host?
Yes. They latch directly onto the human's nasopharyngeal tissue, the back of the throat, the nasal passages, or the tonsils.
That is horrifying in every sense of the word.
It causes severe pharyngeal discomfort, paroxysmal coughing fits, sneezing, and dysphagia, which is difficulty swallowing. It's essentially a live parasite latching onto your throat tissue right in the middle of a meal. It's relatively rare, but it is the ultimate classic warning against eating raw internal organs.
Okay, I think we are ready to move on from that visual. We are officially leaving the water and entering the domain of the eight-legged nightmares.
Section 3.
Chelicerata, the arachnids.
This is a huge, highly important section for clinical medicine. We are talking spiders, scorpions, mites, and ticks.
Let's start with the spiders. Murray sets up this really nice compare and contrast model, the tale of two toxins. We have the black widow on one side and the brown recluse on the other. This feels like an essay question just waiting to happen on a medical board exam.
It is the absolute perfect exam setup because you need to keep them totally distinct in your mind. The visual identification, the clinical presentation, and the underlying pathophysiology are completely opposite to one another.
Let's start with the black widow, Latrodectus mactans.
Visually, she is iconic. Shiny black, very globose, rounded abdomen, and of course the telltale orange or red hourglass marking right on the belly.
And what is her weapon of choice?
Alpha-latrotoxin. It is a highly potent neurotoxin.
Neurotoxin is the critical keyword there. How exactly does it work in the body?
It acts presynaptically. It binds directly to specific receptors on the nerve terminal and causes a massive, chaotic, completely unregulated release of neurotransmitters, specifically acetylcholine and norepinephrine. It basically dumps the nerve entire payload all at once.
So what does that actually look like when a patient walks into the ER?
It's intense and very fast. It starts with a sharp pinprick pain at the bite site, but then usually within an hour, the effects become entirely systemic. You get severe muscle cramps, chest pain, sweating, nausea. But here is the critical red herring for the exam and for the ER doctor. The board-like abdomen.
Explain that for us.
The neurotoxin causes such severe tetanic abdominal muscle spasms that the patient's stomach muscles become completely rigid, literally as hard as a board to the touch.
Which sounds a whole lot like
Appendicitis, peritonitis, or a perforated stomach ulcer, yes. It perfectly mimics an acute surgical abdomen. You have a patient writhing in absolute agony with a rigid belly. A surgeon on call might be very tempted to rush them to the OR and cut them open.
That's an incredibly dangerous mimic.
It is. But there are clinical clues if you look closely. Usually with appendicitis or peritonitis, you have a high fever and a significantly elevated white blood cell count indicating infection. With a black widow bite, you generally do not have a fever, and the white count might be completely normal or only slightly elevated just from the physical stress of the pain.
And if they just pause to take a thorough patient history or look for a bite mark?
Exactly. They might see the faint double red mark on the leg or hear a story about the patient cleaning out an old woodpile or a dark garage an hour ago. You absolutely do not operate on a black widow bite.
How do you actually treat it then?
It's mostly supportive care. Pain control is the absolute priority-heavy intravenous opioids and benzodiazepines to force the muscles to relax. Historically, calcium gluconate was the classic antidote taught in medical schools for decades, but modern clinical research suggests it's not actually that consistently effective. There is a specific antivenin available, but it's generally reserved for very severe cases, like young kids, the elderly, or those with underlying cardiac risks, because the antivenin itself is horse serum-based and can cause severe allergic reactions like serum sickness.
Okay, so to lock that in, Black Widow equals neurotoxin equals rigid abdomen. Now, the challenger in this corner, the brown recluse, Loxosceles.
A totally different beast altogether. Visually, it's a dull yellow-brown color. It has a distinct violin-shaped marking right on the dorsal surface of the cephalothorax, and if you somehow get close enough with a magnifying glass, you'll see it has 6 eyes arranged in a semicircle of 3 pairs, unlike the usual 8 eyes most spiders have.
And its weapon?
Necrotoxin, specifically an incredibly destructive enzyme called sphingomyelinase D.
So we are talking about localized tissue death.
Exactly. This enzyme systematically destroys cell membranes, triggers a massive localized inflammatory cascade, and causes microclots in the local blood vessels. The surrounding skin tissue literally starves of oxygen and dies.
What's the timeline on a bite like that?
The initial bite is very often completely painless. The patient might not even know it happened while they were putting on an old shoe or a jacket from the attic. Then, over a few hours, comes the itching and the swelling. Then a very distinct vesicle or blister forms, often with a dark or bluish center.
The red, white, and blue sign.
Yes, that's the classic description. Red outer ring of inflammation, a white middle ring of ischemia where blood flow is stopping, and a blue or black necrotic center where the tissue is already dead. And then, unfortunately, ulceration. The dead skin slows off and creates a deep, non-healing ulcer that can radiate and spread for weeks.
Is there systemic danger with this spider too, or is it strictly just a skin issue?
There can be a very severe systemic complication called hemolytic syndrome. This involves massive destruction of red blood cells, which can quickly lead to hemoglobinuria, which is dark blood in the urine, and subsequent acute renal failure. This complication is much more common with the South American species, Loxosceles laeta, and it is particularly dangerous in children.
And the treatment. I recall reading something really counterintuitive in the chapter about surgery for these bites.
Yes, this is a very high-yield point. The natural surgical instinct when you see necrotic, dead tissue is to cut it out immediately, debridement. But with a brown recluse bite, you must actively delay debridement.
Why wait? If the tissue is dead and rotting, shouldn't you just remove it to stop the spread?
Not yet, no. Because the necrotoxin actually stays active in the peripheral tissue for a long time, and the inflammatory boundary isn't firmly set in the early days. If you take a scalpel and cut too early, you might actually spread the active toxin deeper into the wound, or you might cut into healthy tissue that was successfully fighting it off. The wound very often gets significantly larger after early premature surgery. You have to wait 3 to 6 weeks until the healing process is naturally started and the boundaries of the necrosis are totally clear and stable.
That is a crucial, do not do this for the listeners. Do not surgically cut a brown recluse bite early.
Correct. You use ice, elevation, thorough wound care, and time. Dapsone is sometimes used off-label to prevent the necrosis, but the clinical evidence for it is actually quite mixed.
Before we completely leave the big arachnids, let's quickly touch on scorpions, specifically the centauroid species found in the southwest United States and down into Mexico.
Scorpions are geographically interesting. Most scorpion species in the U.S. are essentially just like severe bee stings, very painful, but medically harmless for the most part. But the bark scorpion, Centauroides sculpturatus, is the major exception.
What's the specific demographic risk here? Who needs to be worried?
It is a major pediatric emergency. For most healthy adults, a centroid sting just causes severe local pain and maybe some paresthesia, which is numbness or tingling that taps up the limb. But for small children, specifically those under 5 years old, the neurotoxin can cross over and cause an autonomic storm.
What does an autonomic storm actually look like in a pediatric patient?
It is terrifying for the parents. The child will be thrashing wildly. They have roving, uncoordinated eye movements, excessive drooling and salivation, and severe respiratory distress. It can absolutely be fatal due to respiratory failure if not managed quickly.
So if you were working in ER in Arizona and a frantic parent brings in a kid who is drooling, thrashing, and has weird eye movements, think scorpion sting.
Absolutely. And the good news is there is a highly effective specific antivenom called Antiscorp that essentially works wonders and reverses the symptoms very rapidly.
All right, let's shrink things down significantly. Section 4, mites, the microinvaders. These are the arachnids you can barely even see, but you most certainly feel them.
Mites are truly ubiquitous in our environment, but let's focus on the one causing the absolute most misery in human populations, Sarcoptes scabiei, the itch mite.
The silent burrower.
That is a very accurate name for it. The pregnant female mite literally tunnels down into the stratum corneum of the epidermis, the top layer of your skin, just to lay her egg. She lives her whole life in that tiny tunnel.
I am literally itching just hearing you describe that.
It is the clinical definition of severe pruritus. It's historically known as the 7-year itch. But here is the really interesting immunological mechanism that students often miss. The severe itching isn't just the physical sensation of the mite crawling around. It is actually a type 5 delayed hypersensitivity reaction. You are developing an allergic reaction to the physical mite, to its eggs, and to its feces left in the burrow.
So that means the itch takes time to actually develop.
Exactly. If it is your very first time getting infected with scabies, it might take several weeks for your immune system to fully recognize the antigens, ramp up, and for the severe itching to actually start. But if you get reinfected a year later, the itching starts within 24 hours because your memory T cells are already primed and ready to attack.
And there's a very specific physical geography to this rash, right? You don't just look everywhere.
Yes, you must look at the web spaces of the fingers, the interdigital folds. That is prime real estate for scabies. Also, the flexor surfaces of the wrists, the inguinal region, and the axilla. If you see tiny serpiginous tracks or burrows in the finger webs and the patient is scratching like crazy, especially at night when the mites are more active, it is scabies until proven otherwise.
And it's highly contagious, I assume.
Extremely. It requires prolonged direct skin-to-skin contact. It spreads like absolute wildfire in nursing homes, daycares, prisons, and crowded living conditions. It can also easily be sexually transmitted.
What's the standard fix for it?
A topical 5% permethrin cream, and this is the key instruction you have to give patients. You have to apply it systematically from head to toe or neck to toe for adults. You cannot just treat the itchy spots because the microscopic mites could be migrating anywhere on the body. Leave it on overnight, wash it off in the morning, and you absolutely have to wash all clothing and bedding in very hot water.
You mentioned nursing homes and daycares. What about the other major mite mentioned, the chigger?
Chiggers. These are actually just the larval stage of the trombiculid mite. The adult mites are vegetarians. They don't bite humans at all. Only the microscopic babies do.
And where do they tend to strike on the body?
They love areas where your clothing is tight against the skin. Waistbands, ankles under tight socks, the groin. They don't actually burrow into the skin like scabies. Instead, they inject potent digestive enzymes directly into the skin, which literally liquefies your epithelial tissue so they can just slurp it up.
A liquefied skin smoothie. That's lovely.
Essentially, yes. And as your body reacts to the enzymes, it hardens the surrounding tissue, and the chigger actually forms a tiny biological drinking tube called a stylostome out of your own hardened skin cells to drink the liquefied tissue through. This process causes incredibly intense localized dermatitis.
And Joe, it links these specific chiggers to a major infectious disease, right?
Yes, mostly in Asia, the Pacific Islands, and northern Australia. In those regions, chiggers are the primary vector for scrub typhus, which is caused by the bacteria Orientia tsutsugamushi. This was a massive medical issue for soldiers fighting in the Pacific Theater in World War II and later in Vietnam.
Okay, one more mite before we move on. Demodex?
The human face mite. It lives head down in our hair follicles and sebaceous glands. Frankly, most of us listening to this right now have them, living peacefully on our eyelashes or the pores of our nose.
Thanks for that wonderful reminder. I'm sure the listeners appreciate feeling them crawl right now.
They are usually totally harmless commensals. They just eat excess sebum and dead skin cells and leave us alone. But in highly immunocompromised patients, like those with untreated AIDS or those on heavy immunosuppressants, the Demodex population can overgrow massively and cause a very severe inflammatory folliculitis.
All right, moving on to the heavy hitters of the arachnid world. The ticks, Section 5.
Ticks are essentially the heavy tankers of the vector world. They are physically robust, they feed for a very long time, and they carry a massive, diverse payload of pathogens.
Before we get into the specific diseases they carry, we really need to understand the biology. Why are ticks such incredibly good vectors compared to a mosquito?
It all comes down to their feeding time. Unlike a mosquito that lands, sips, and zips away in 5 seconds, a hard tick attaches to your body for days. It physically cements its mouthparts into your skin using a specialized protein glue.
And while it's sitting there for days, it has to modulate the host immune system, right? Otherwise, we would notice it.
It absolutely has to. To hang on to a mammalian host for up to a week without being violently rejected by the immune system, the tick's saliva has evolved into a highly complex pharmacy. It contains potent anticoagulants to stop the blood from clotting, localized anesthetics so you don't feel the initial bite or the burrowing, and powerful immunosuppressants to physically stop your white blood cells from attacking the site.
That is just incredibly sophisticated biological warfare. Let's break down the taxonomy. We need to distinguish hard ticks from soft ticks.
Hard ticks, the Ectoparasites family, have a hard chitinous shield on their back called a scutum. They are the siege warfare specialists. They ambush you from tall grass, latch on, and they stay there feeding slowly for days, sometimes up to 7 to 9 days if undisturbed.
Which, thankfully, gives you some time to find them.
Theoretically, yes. That's exactly why doing daily tick checks after a hike actually works. If you find them and remove them early, very often pathogen transmission hasn't happened yet. For example, with Lyme disease, the bacteria is dormant in the tick's gut. It usually takes 24 to 48 hours of constant, warm blood feeding for the bacteria to activate and migrate to the salivary glands to be transmitted.
And what about soft ticks, the Argacidae family?
They're totally different. They are leathery, they have no hard scutum, they're more like guerrilla fighters. They live deep in the nest, the cave, or the burrow of the animal host. They run out at night, bite the host for maybe 20 minutes, drink their fill rapidly, and run right back into the cracks. You very rarely ever find a soft tick actually attached to you.
Now, there's a specific acute condition called tick paralysis, and I want to be very clear for the students, this isn't an infection like Lyme. Okay.
Correct. This is a purely toxin-mediated illness. It's not a bacteria or a virus. Some species of female ticks secrete a potent neurotoxin in their saliva, specifically while they are actively feeding and engorging.
What does that patient look like when they present?
It classically presents as an acute ascending flaccid paralysis. It starts in the lower extremities. The child becomes clumsy, has trouble walking, maybe falls down. Then over a few days, it moves up to the trunk, the arms, and finally, tragically, the respiratory muscles. Clinically, it looks almost exactly like Guillain-Barré syndrome.
How does an ER doctor tell the difference between the two?
You have to meticulously search every single inch of the patient's skin, especially the hidden areas. You comb through the scalp, check behind the ears, look in the axilla, the groin, the belly button. If you find the engorged tick and physically remove it, the paralysis reverses itself incredibly rapidly.
How rapidly are we talking?
Within hours to maybe a day or two. It's truly dramatic. It's a total HouseMD diagnostic moment. You find the hidden tick, pull it out, and you completely cure the paralysis. But if you fail to do a thorough skin check and miss it,
then what?
The paralysis reaches the diaphragm, causes respiratory failure, and the patient dies. So the rule is always, always deeply check the scalp and hairline in any patient presenting with an unexplained acute paralyzed state.
Wow. Now let's do a rapid-fire association for the major tick vectors. I'll name the specific tick genus, and you give me the key diseases and the why behind it. Hit me. Dermacenter, the American dog tick or wood tick.
You need to immediately think Rocky Mountain spotted fever, caused by rickettsiae. Dermacenter is a classic 3-host tick, meaning it drops off and jumps to a completely new host at each of its 3 life stages. This behavior massively increases its chance of picking up bloodborne pathogens from rodents and passing them to dogs or humans. It also carries tularemia.
Okay, next, ixodes. The deer tick or black-legged tick?
The big one everyone knows is Lyme disease, caused by Borrelia burgdorferi. It also vectors babesiosis, which is a malaria-like red blood cell parasite, and anaplasmosis. Ixodes is physically much smaller than Dermacenter. In its nymph stage, which is when it bites humans most often, it's about the size of a poppy seed, which is exactly why it's so frequently missed during tick checks.
Amblyoma. The Lone Star tick.
For infections, think ehrlichiosis. But very interestingly, it's also strongly associated with the emerging red meat allergy, also known as alpha-Gal syndrome, though to be clear, that's an immunological allergic side effect to a sugar molecule in the tick's saliva, not a bacterial infection.
Finally, Ornithodoros,
Yeah.
the soft tick.
Think relapsing fever caused by Borrelia species. Because soft ticks live in burrows and feed very quickly and repeatedly on many different rodents over their lifespan, they are the absolute perfect mechanism for keeping a bacterial population continuously circulating within a rodent colony.
Let's talk about that specific amblioma case study from the Murray text, African tick bite fever.
This is a classic emerging infection scenario in returning travelers. A patient returns home from an eco-tour or a safari in Zimbabwe, South Africa, or sub-Saharan Africa. They present to the clinic with fever, muscle aches, flu-like symptoms.
And what is the specific physical clue you're looking for?
An inoculation Escher. You look at their legs or torso and find a distinct black, crusty, necrotic scab right where the tick originally bit them. Sometimes there are multiple Eschers.
And the specific pathogen is?
Ricketsiae africae. Now, unlike Rocky Mountain spotted fever, which can be rapidly fatal, this African variant is usually much milder. But that black Escher is the absolute diagnostic giveaway. If you see an exam question with the words Escher plus African safari, you just automatically click African tick bite fever.
Okay, we are officially leaving the ground. Hexapoda, the insects, the flying vectors.
The Diptera, the two-winged flies and mosquitoes. We need to respect this group because, statistically speaking, these are the absolute most dangerous animals on planet Earth. They have directly killed more humans throughout history than all of our wars combined.
Let's break down the mosquito big three. You can't just broadly say mosquito in tropical medicine. You have to know the specific genus. First up, Anopheles.
The primary malaria vector, public enemy number one. Biologically, they are very unique. When they land on your skin, they rest with their abdomens pointing up at a distinct 45-degree angle to the surface, and crucially, they are almost exclusively night biters.
Which directly informs our public health prevention strategies.
Exactly right. This is precisely why insecticide-treated bed nets work so miraculously well for malaria control. If the primary vector only bites at night while the host is sleeping, a simple net over the bed is a perfect, highly effective shield.
Second genus.
Aedes.
Specifically E. aegypti.
The tiger mosquito. Visually distinct. It's dark black with bright white, lyre-shaped stripes on its body and legs. These are the classic container breeders. They don't need a swamp. They love flower pots, discarded old tires, small puddles of trash water in densely packed urban areas.
And their feeding behavior.
They are highly aggressive daytime biters. They're the ones that bite your ankles repeatedly while you are sitting outside having lunch in the afternoon.
So all those bed nets we just talked about
Are completely useless against Aedes. You are awake and out of bed when they hunt. You need strong chemical repellent, long clothing, and to dump out standing water around your house. They transmit some severe viral hemorrhagic fevers and arboviruses, yellow fever, dengue, chikungunya, and Zika. They are truly the vectors of modern urbanization.
And the third major mosquito genus, Culex.
This is your standard common house mosquito. They tend to breed in really dirty, stagnant, organic-rich water, think open sewers, storm drains, and catch basins. In North America, they are the primary vector for West Nile virus and St. Louis encephalitis.
It's amazing how highly specialized each of them are. It's like a massive evolutionary chess match.
It really is. Different mosquito species, completely different breeding habitats, totally different active feeding times, and they carry very different diseases. You absolutely cannot treat mosquito control as a single monolith.
Let's move from mosquitoes over to the true flies. Sandflies first. The genus Phlebotomus.
These are tiny, silent, very fragile flyers. They actually seem to hop around more than they fly, but they are the dreaded vector for leishmaniasis, which is a protozoan parasite, and sandfly fever, which is viral.
The bite is described in the text as being particularly painful.
Very painful and highly pruritic. What happens in leishmaniasis is the sandfly takes a blood meal, but the parasites multiply in its gut and actually block its throat. So when it tries to feed again, it has to forcefully regurgitate the promastigotes directly into the human skin wound. This injection can lead to cutaneous leishmaniasis, which causes huge, disfiguring skin ulcers, or visceral leishmaniasis, also known as Kala-Azar, which attacks the liver, spleen, and bone marrow, and is often fatal if untreated.
Then we have black flies, the genus Simulium.
These require highly oxygenated, fast-flowing rivers to breed. They attach their larvae to rocks in the rapids, hence the name of the terrible disease they carry, river blindness, caused by the helminth onchucerca volvulus.
They look quite different from other flies too, don't they?
Yes, they are stout, they look almost like little humpbacked buffalo, and their mouth parts are brutal. They don't have a delicate, needle-like proboscis like a mosquito. They essentially have serrated blades. They violently slash the skin open to create a physical pool of blood, and then they just lap it up like a dog drinking water.
That is just brutal.
It is. And that open pool of blood is exactly where the onchocerca microfilaria enter the human body to start their life cycle.
And there is a specific allergic syndrome mentioned called black fly fever.
Yes, if you get swarmed by hundreds of them, say you are camping in northern New England or up in Canada during black fly season, the sheer massive volume of fly saliva injected into your body can cause a severe systemic hypersensitivity reaction. You get a pounding headache, high fever, swollen lymph nodes, nausea. It's important to note it's not an actual infection. It's basically an allergic toxicosis reaction to the spit itself.
Next on the list, tsetse flies, the genus Glossina.
The infamous vector of African trypanosomiasis, better known as African sleeping sickness. These are physically large, robust flies, about the size of a regular housefly, but they fold their wings completely flat over their back, and they have a very distinct hatchet-shaped cell pattern in the wing veins.
What's a bite like?
Deep, immediate, and incredibly painful. They have a rigid proboscis that can bite right through canvas or thin clothing. They inject the trypanosome protozoa, which eventually cross the blood-brain barrier. That leads to the profound meningoencephalitis that causes the classic sleeping symptoms: total reversal of sleep and wake cycles, severe confusion, personality changes, and eventually a terminal coma.
Before we finally land the flying section, we absolutely have to talk about meiosis, maggot infestation.
Yes. This is where the fly larvae actually develop and feed inside living human tissue. It's not just a quick bite, it's a sustained parasitic invasion.
A human botfly, Dermatobia hominis.
This is truly the stuff of horror movies. The adult female botfly is large and looks somewhat like a bumblebee. She wants to put her eggs on a human or animal host, but she's too big and noticeable, so she actually captures a mosquito midair.
She catches a mosquito. That is some incredibly complex evolutionary behavior.
It is. She holds the mosquito, glues her own egg securely to the mosquito's abdomen, and then just lets it go unharmed.
So the mosquito becomes her delivery system.
Exactly. The mosquito flies off, lands on a human, and starts to bite. The warm body heat from the human skin triggers the botfly eggs to instantly hatch. The tiny maggots drop right off the mosquito onto the skin, and they crawl straight down into the exact puncture wound the mosquito just made.
And then they just grow in there.
They grow very quickly. The clinical case study in Murray describes a clastic furuncular lesion, which looks exactly like a large staph boil that simply refuses to heal. It has a tiny, distinct central pore or hole in the top so the maggot can breathe air.
And what does the patient actually feel?
This is the worst part. The patient typically reports a very distinct sensation of movement inside the boil because the larva is covered in concentric rings of sharp backward-pointing spines to tightly anchor itself in the flesh. Every single time it wiggles or moves, those spines scrape against the nerve endings in the tissue.
How do you treat it? You can't just take tweezers and pull it straight out.
Yeah. No, absolutely do not do that. Those backward-pointing spines anchor it like a fishhook. If you grab it and pull hard, you will rip the larva in half, leaving the dead lower body rotting deep inside the skin, which guarantees a severe secondary bacterial infection. You have to cleverly force it out by suffocating it.
The bacon therapy. I remember seeing this in a tropical medicine video.
Exactly. You thickly cover the central breathing pore with a heavy layer of petroleum jelly, thick nail polish, or traditional field medicine dictates a heavy piece of raw bacon fat. You block its air supply. The larva literally can't breathe. So after a few hours, it slowly extends its body upward, pushing out of the hole to search for fresh air.
And then you grab it.
Then once it's poking out, you carefully grab it with forceps and gently extract it. It is incredibly satisfying for the doctor and incredibly gross for everyone else in the room.
I think I need a deep breath after that one. But we have to press on to the final group. Section 7. The crawlers. Lice, fleas, and bugs.
Let's start by really clarifying the clinical lice situation. It's not just one generic bug. You have head lice and you have body lice. Biologically, they look very, very similar under a microscope, but clinically and epidemiologically, they are worlds apart.
Head lice, Pediculus humanus capitis, those are mostly just a massive nuisance, right? Kids get sent home from elementary school.
Correct. They live entirely on the scalp. They cement their eggs, which are called nits, firmly to the base of the hair shaft. They feed on blood, which causes intense localized itching, social embarrassment, and anxiety for the parents. But, and this is a huge high-yield exam, point head lice do not transmit any major infectious diseases.
But body lice.
Pediculus humanus, these are the historical killers. They are unique because they do not actually live on the human skin. They live, breed, and lay their eggs deep in the seams of clothing.
So they essentially just commute to work on your skin.
Exactly. They only move from the fabric to the skin surface for a quick blood meal, and then they retreat right back into the warm clothes. This is precisely why they are intrinsically associated with times of war, refugee crises, homelessness, and severe poverty situations where people simply cannot regularly change or wash their clothing in hot water.
And what do they carry that makes them so deadly?
Epidemic typhus, caused by Rickettsiae prowazekii. This single disease has literally decided the outcome of major wars. Napoleon's devastating retreat from Moscow was largely driven by his army being decimated by louse-borne typhus, not just the Russian winter.
How is it actually transmitted, though? Because the text said it's not the physical bite itself that infects you, right?
That's correct. The louse feeds on an infected person. The Rickettsia bacteria massively multiply inside the louse's gut. When the louse crawls onto a new human to feed, it defecates while it eats. The human feels the itchy bite, reaches down, and aggressively scratches the area, inadvertently rubbing the highly infectious louse feces directly into the microabrasions of the bite wound.
Disgusting, but incredibly efficient from an evolutionary standpoint. So, to summarize for exams, head lice equals itchy nuisance. Body lice equals epidemic typhus.
Precisely. Keep those separated in your mind.
Now let's tackle fleas. The Siphonaptera order.
The absolute most important one historically is the oriental rat flea, Xenopsilla chiapis. It is the primary vector for the plague, Yersinia pestis, and also murine typhus.
I want you to explain this because I found it fascinating. This involves the blocked flea mechanism, isn't it?
Yes, it's a brilliant and terrible mechanism. The plague bacteria multiply so rapidly inside the flea's tiny gut that they actually secrete a thick gel-like biofilm that completely blocks the flea's digestive tract. The flea physically cannot swallow any more blood. It feels like it is starving to death, so it becomes frantic. It jumps onto a human, bites aggressively, but the blood hits the blockage and bounces back. The flea is forced to regurgitate the blood along with massive clumps of plague bacteria directly back into the human's bite wound, trying to clear its own throat. A starving, vomiting flea is a terrifyingly efficient biological vector.
Truly nightmare fuel. But there is another flea mentioned, totally different mechanism. The chigo flea, Funga penetrans.
Also known as the burrower or the jigger flea. This is very common in specific tropical regions, particularly parts of Africa, South America, and the Caribbean.
How does it attack differently than a rat flea?
It doesn't just bite and run away. The female chigo flea finds a host and burrows headfirst deep into the skin, usually on the soles of the feet, between the toes, or right under the toenails of people walking barefoot.
And she just stays buried in there.
She stays there permanently. Over the next week, her abdomen swells massively with thousands of developing eggs, growing from a microscopic speck to about the size of a small pea. This massive expansion causes a very painful, intensely inflammatory, ulcerating lesion called tungiasis.
And what is the classic visual clue for a clinician?
You look at the patient's foot, and you see a firm, white nodule with a very distinct central black dot. That black dot is actually the flea's posterior end. It leaves its breathing spiracles and its reproductive organs exposed to the outside air so it can breathe and eventually shoot the eggs out onto the soil.
So if a patient walks into your clinic after walking barefoot on a beach in Brazil and they have a painful nodule on their toe with a central black dot, you know exactly what that is. It's Tunga.
Exactly. And the treatment is sterile, surgical extraction of the entire intact flea, followed by a tetanus shot just to be safe.
Finally, we arrive at the true bugs, the Hemiptera order. We need to compare bed bugs and kissing bugs.
Bed bugs, genus Cimex, are unfortunately back in a very big way globally. They are small, reddish-brown, flat, wingless insects that hide in mattress seams and baseboards.
What's the classic dermatological bite pattern they leave behind?
They typically bite in a distinct linear pattern. Dermatologists often call it the breakfast, lunch, and dinner sign. You'll see 3 highly itchy red welts right in a row, usually on the exposed trunk, the shoulders, or the arms.
And the big question, Are they vectors for anything serious?
Surprisingly and thankfully, no. Despite the fact that they feed exclusively on human blood and move from person to person in hotels, large-scale studies have not proven them to be significant vectors for any human disease. They cause severe psychological anxiety, insomnia, and secondary skin infections from scratching, but they are not spreading typhus or HIV or plague.
Contrast that benign nuisance with the tritomid bug, the kissing bug.
A completely different scenario. These are much larger winged bugs. They are primarily found living in the cracks of mud or adobe walls and thatched roofs in rural parts of Latin and South America.
Where do they typically bite on the human body?
They hunt at night, and they tend to seek out the exposed areas of a sleeping person's face, often biting right around the thin skin of the eye or the lips.
Which is how they got the creepy nickname, the kissing bug.
Right, and they are the primary vector for Chagas disease, caused by the parasite Trypanosoma cruzi, which can lead to fatal heart failure years later.
And again, with the transmission, is it the bite itself injecting the parasite?
No, it's the poop and scratch method once again. The kissing bug feeds, gets full, and defecates right next to the bite wound. The sleeping victim feels the tickle, reaches up, and rubs the infectious feces directly into the bite puncture or directly into the conjunctiva of their eye.
And that leads to a very famous clinical sign.
Romagn's sign. It presents as a massive unilateral painless swelling of the upper and lower eyelid. If you see a heavily swollen eye on one side of the face in a patient from rural South America or who just returned from staying in rural housing there, you must immediately think acute Chagas disease.
So to quickly summarize the bugs for the exam, bites on the arm in a straight line equals bedbug, which is just a nuisance. A bite on the eye resulting in unilateral swelling equals a kissing bug, which means Chagas disease.
That is exactly the mental model you need to lock in.
Wow. We have covered a truly massive amount of ground today. From the ocean to the forest, from the mattress to the African safari. I think it's time to test if any of this actually stuck with our listeners.
Let's do the rapid recall section. This is crucial to help consolidate the memory right now while it's fresh.
Okay, listeners, here is how this works. I'm going to read a short clinical vignette and ask a question. I will pause for a second. Please hit pause in your podcast player if you need more time to think, and then the expert will give the final answer and explain the why behind it. Let's get started. Question 1. A patient is rushed to the ER complaining of severe, agonizing abdominal pain. Upon physical examination, the abdomen is remarkably rigid and board-like. However, the patient has no fever and their white blood cell count is completely normal. A small, faint red mark is found on the patient's lower leg. Which arthropod is responsible for this presentation?
The answer is the black widow spider, Latrodectus mactans, and here is the why. The spider injects alpha-latrotoxin, which causes a massive chaotic release of acetylcholine at the nerve terminals. This leads to severe tetanic muscle spasms that perfectly mimic an acute surgical abdomen. The distinct lack of fever and a normal white count are the key clues that help distinguish it from a true bacterial peritonitis or appendicitis.
Question 2. A traveler returning from a 2-week photographic safari in Zimbabwe presents to your clinic with flu-like symptoms, including fever and muscle aches. During the skin exam, you find a distinct black, necrotic, scab-like eschar on their right calf. Which tick genus is the likely vector?
The vector is the Amblyomma tick. Why? This clinical picture describes African tick bite fever, which is caused by Rickettsia africae. The Amblyomma tick is the primary vector for this disease in sub-Saharan Africa. The presence of the black inoculation eschar is the absolute hallmark diagnostic clue.
Question 3. A 5-year-old child develops acute ascending flaccid paralysis starting in the legs just a few days after a family camping trip. The child has no fever, no headache, and a lumbar puncture shows completely normal CSF. What is the immediate curative medical treatment for this patient?
The treatment is to meticulously locate and physically remove the tick from the child's body. Why? This is a classic presentation of tick paralysis. It is fundamentally caused by a continuous salivary neurotoxin secreted by the feeding tick, not by an actively replicating bacterial or viral infection. Complete removal of the tick immediately stops the toxin source, and the patient's neurological recovery is typically rapid and complete.
Question 4. A patient presents to a tropical medicine clinic with a very painful, inflamed, ulcerating lesion on their big toe after spending several weeks walking barefoot on the beaches of Brazil. Upon close inspection, a small dark spot is clearly visible directly in the center of the white nodule. What is this specific organism?
Tunga penetrans, commonly known as the chigo flea. Why? The pregnant female flea physically burrows headfirst into the skin of the foot to gestate and lay her eggs, causing the painful condition known as tungiasis. That characteristic dark spot you see in the center is actually the posterior end of the flea, which remains exposed to the air for breathing.
Question 5. Which specific species of louse is considered the primary vector for epidemic typhus?
The body louse. Pediculus humanus humanus. Why? It is critical to remember that head lice and crab lice are generally not significant vectors for typhus. Body lice uniquely live and lay their eggs in the seams of clothing, making them deeply associated with the poor hygiene, crowding, and wartime social conditions where typhus historically spreads and thrives.
Question 6. Clinically, how do you differentiate the typical bite pattern of a common bedbug versus a triatomid, or kissing bug?
Bedbugs characteristically bite in linear patterns, often leaving 3 sequential bites on exposed areas like the trunk or arms, giving the breakfast, lunch, dinner sign. Triatomid bugs, however, specifically target the face while the host is sleeping, often causing severe unilateral periorbital edema, which is known as Romagnea sign, and they transmit Chagas disease.
How did you do? If you missed any of those, I highly encourage you to go back and actively review Murray Chapter 77, specifically focusing on the summary tables linking the specific vectors to their respective diseases.
And remember the big picture here. Arthropods are truly the master delivery systems of the microbial world. As physicians, we can always try to treat the internal parasite with drugs, but historically and practically, true disease control almost always lies in managing the external vector.
It's the ultimate host-vector chess match. Drain the swamp, clear the rubbish around the house, check your hairline for ticks, and, maybe don't eat raw sheep liver.
That is extremely sound advice for both life and medicine. And as global climates shift and warm, the geographic ranges of all these vectors are expanding. Diseases we thought were isolated to the tropics are slowly moving north. So this information is only going to get more relevant for daily clinical practice.
Absolutely. Keep your skin covered, keep your eyes open, and we will catch you on the next deep dive.
Stay safe out there.